Hey, good morning, everybody. Well, good morning here, at least in Honolulu. Thank you, everybody, for taking the time to join our webinar today titled Healing Waves, How Hawaii is Turning the Tide on Cancer Inequities. Now, I have to thank Haley Honeycutt, who is our AACI program coordinator, for coming up with this very creative title, because it's certainly something that I wouldn't have been able to do. My name is Stephanie Seelam, and I am an oncologist here at the University of Hawaii Cancer Center. So we have two fantastic speakers today, of which I'm so excited to welcome, both of whom are experts in health disparities within the Native Hawaiian and Pacific Islander population. So first, we have Dr. Kevin Castle, who is an associate professor in the Population Sciences Pacific program. He's also the Associate Director in the Community Outreach and Engagement Office here, and his research explores ways to implement effective cancer control interventions by working with the communities like the Native Hawaiian and Pacific Islanders who are experiencing cancer health disparities. Our second speaker is Dr. Neil Palafox, who is a professor in the Population Sciences in the Pacific program and in the Department of Family Medicine and Community Health here at the John A. Burns School of Medicine. And Dr. Palafox's career has really been focused on improving health capacity and health policy towards reducing health disparities in the populations of the Pacific Islands. And this work is done utilizing a community-based participatory approach and developing key partnerships with health leaderships, policymakers, and community advocates throughout the Pacific Islands and within the Micronesian communities here too within Hawaii. So as an introduction, I'll kind of start with a global perspective on why Hawaii and the Pacific Islands is really what I call the perfect storm for propagating health disparities. Now, first, we are located about 2,500 miles away from the nearest city on the mainland, which is, as some of you know, at least a 5 to 6 hour flight time. And so this distance really creates a lot of barriers that are unique to our medical landscape, like access to novel therapies, clinical trials that are often offered on the mainland, but just are not available here. So as a clinician, we see patients not just from Oahu, but we also see a lot of patients from Pacific Islands like the American Samoa, Marshall Islands, Micronesia, and even really far away places like Yap. I think if we were doing this person, I would poll you guys because not a lot of people actually know where Yap is. I know I certainly didn't, but Yap is a very small island which is located about 12 hours by flight to Oahu. And so access to quality healthcare for these patients are even more challenging. So, for example, recently I saw a patient from Yap who was diagnosed with high-risk Hodgkin's lymphoma. And so his diagnosis, I would say, is arguably delayed by about 6 months because of a lack of access to just basic equipment like a chest X-ray machine to look for a mediastinal mass, even though he had symptoms of cough, fever, night sweats for months. And on top of that, even though we have cured him, follow-up care is always really challenging for these patients because to expect them to fly from Yap to Oahu or Honolulu every month for follow-up imaging, labs, etc., when he's going to lose his Hawaii license or insurance status when he goes back home is kind of not feasible because their minimum wage is $2 an hour. And so there's just a lot of kind of things that I know I never thought about when I was doing my training on the mainland. Not only that, Hawaii is also a majority minority state, meaning that the non-Hispanic white comprise of less than 50% of our population. We have the largest multiracial population within the United States, with 26% Filipino, 22% Japanese. We have 20% Native Hawaiians, 14% Chinese, and 11% Hispanics. And of these racial groups, Native Hawaiians and Hispanics have the lowest median family income, with 16% of Native Hawaiians living at or below the poverty level, and over 15% of them are uninsured. And unfortunately, when you compare it with the other kind of major ethnic groups, the overall, oops, here we go. The overall cancer incidence rate is actually highest for Native Hawaiian women, and the overall cancer mortality rate is highest for both Native Hawaiian men and women. And of course, last but not least, Hawaii faces a shortage of almost 800 full-time equivalent physicians, and that's partly due to lower pay caused by the state general excise taxation on medical services, on top of course, the very high cost of living that we have here. And the shortage is most acute on neighbor islands where the lack of oncology specialist drives patients from the neighbor islands or even Pacific Islands to come to Oahu or Honolulu for care. And so today I'm really excited to learn from Dr. Castle and Dr. Palafox on the really historical perspective on how these health equities came to be and why these disparities disproportionately affects the Native Hawaiian and Pacific Islander populations. And then, of course, we'll end with what steps we're taking here at the University of Hawaii Cancer Center to address these cancer inequities. So with that said, I'm going to pass it over to Dr. Castle. Kevin, I think you have to unmute.
Oh, thank you, Dr. Lim. It's a pleasure to be here with you all and to share this presentation with you all. I am Kevin Castle. I'm at the University of Hawaii Cancer Center. I am an associate professor in the Population Sciences in the Pacific program and also associate director of our Community Outreach and Engagement Office. And I'm going to talk a little bit about Native Hawaiian communities here in Hawaii and give some background on some things that we're doing to address some of the disparities that you have mentioned. So this is a brief agenda, and I do need to say I have no conflicts of interest with anything that unfortunately have no conflicts of interest with anything that's going to be presented today. And I just want to state that I've been here in Hawaii for over 30 years and been working on these disparities for over 30 years. But today I'm going to give a brief background about Hawaii, some of the health disparities and causes that we experience. I want to talk about the cultural renaissance that we are experiencing here in Hawaii and some of our interventions. We are using culture as an intervention to address some of the disparities that are experienced here. And then finally, I'm going to talk about future plans and next steps. So, as you mentioned, we serve a vast catchment area. This covers millions of square miles, mostly ocean. It includes the state of Hawaii as well as the territories of Guam and American Samoa, as well as the Commonwealth of the Northern Mariana Islands, Republic of the Marshalls, Palau, and Federated States of Micronesia. So, this is a vast and wide area that we cover in terms of the University of Hawaii Cancer Center. There are some misconceptions about Pacific Islanders and Hawaii in particular. People imagine pristine beaches, clear blue oceans, and clear blue skies, and that is the case. But often they do not know about some of the disparities, the abject poverty that is experienced here in the islands. This is a shot of downtown Honolulu recently. A lot of homelessness, a lot of homeless encampments. We do have public housing, structures that are here pictured here, as well as we have Hawaiian homesteads. These are appropriate lands. This is a homestead in Papakolea for Native Hawaiians. As you can see, the structures are built on these really steep areas, which would be, very difficult for people who are elderly to access their abodes. So we do have a lot of challenges here in Hawaii as it relates to lifestyle. So just to give some background, prior to Western contact, uh, Native Hawaiians and Pacific Islanders were really, really healthy. These were people who migrated from Southeast Asia. Uh, the original culture was the Lapita culture. The people who initially migrated were selected for long ocean voyages, had metabolic efficiencies. They brought indigenous foods, taro and other products to help sustain them on these long voyages. And before Western influence, diseases and natural hazards were limited. Cultural practices reduced illnesses. There was meticulous hygiene. People were physically active. And the traditional diet for Pacific Islanders was very, very healthy: vegetables, fruits, and lots of seafood. But post-Western contact, 1722, infectious diseases decimated about 70 to 90% of the population. Smallpox and syphilis were some of the key, uh, you know, infectious diseases that were prevalent during that time. And in addition to the infectious diseases, lack of access to traditional food products became apparent. There was not an availability of natural foods and an adoption of Western dietary patterns, including McDonald's. This is one of the McDonald's that's in American Samoa. It's one of the most uh, profitable McDonald's in the world. And the access to fresh fruits and vegetables became limited. Processed foods and prepackaged foods became, prominent in Pacific Islander and in Hawaii as well. So there are what we call social and cultural determinants of health. Cultural factors contribute to health disparities, including depopulation, as I mentioned, the decimation through infectious diseases, subjugation, land dispossession, and relatively poor social and economic indicators found among Hawaiians, including lower incomes, lower rates of home ownership, and educational attainment. And this land dispossession, people, we need to be mindful. In Hawaiian culture, there's a tremendous affinity with agriculture and with the land. It's actually part of the mythology of or religious practices of Hawaiian people. The taro plant is seen to be the elder brother of humanity, and they really revere the importance of agricultural and land possession terms of sharing resources. So this is a challenge for folks. So because of these factors, there's been a lot of detrimental health behaviors that have been adopted. Elevated tobacco and alcohol use, diets, as I mentioned, high in fat and energy. So this contributes to the disparities. These are some of the disparities we see relative to Native Hawaiians. Cancer rates are about 90% higher than the general state population. Diabetes rates 140% higher than the general state population. Heart disease 113% higher. Lower lower respiratory disease 30% higher. So these are the challenges experienced by Native Hawaiians across the board in the state of Hawaii. As mentioned, we have a wide, vast area that we serve. Uh, Despite a population of 2 million people, we have over 10,000 cancer cases in the region that we need to address on an annual basis. Some of the more, and also there are some cancers that are more common in Hawaii than in the US. Breast cancer incidence rates are higher in Hawaii. Colorectal cancer incidence rates are higher. Endometrial cancers, liver cancers, thyroid, pancreatic, and stomach cancers are also very high as compared to the US incidence rates. So this leads to the fact that we address some priority cancers in terms of our research and our outreach. We look at cancers where we can have a tremendous impact. Those would be lung, liver, colorectal, and breast cancers. But there are other cancers we address, and this is based upon community input, the disease burden. We monitor our cancer burdens over time to look at things that we may need to address, emergent sites that may need to be addressed, as well as disparities and critical mass of our investigators here at the University of Hawaii Cancer Center. So as mentioned, among the top ethnic groups in Hawaii, Native Hawaiians, although the incidence rates are not particularly higher than most, the mortality rates are higher for both men and for women for Native Hawaiians. And this is for all cancers. And this is a tremendous trend that we need to address. The fact that more Native Hawaiians are dying than any other ethnic group in the state. However, there's good news. The Hawaiian cultural renaissance has been a vehicle to promote health and health advocacy for the Native Hawaiian community. It's generally recognized as having begun in the 1970s. It's a time of significant revival of traditional Kanaka or Native Hawaiian culture. It revitalized the Hawaiian language, revitalized traditional arts, music, and dance, and increased political activism and advocacy for Native Hawaiian rights. So this has been an impetus for a lot of the health promotion activities that we are experiencing now. Part of that cultural renaissance was the establishment of the Native Hawaiian Healthcare Act. This established healthcare centers throughout the state, Native Hawaiian Healthcare Systems Office in each county to provide equitable access for communities to healthcare. And this has really been really important. as well as resurgence in cultural practice. This is the Kalo field, and as you can see, it's a very labor-intensive practice to grow and harvest kalo. People have seen and heard about the hokulea, the resurgence of the Hawaiian voyaging processes. And one of the things that we're focusing on right now at the Cancer Center is using these cultural practices as components of interventions to improve health outcomes. So this process was begun in 1989, led by Dr. Kakuni Blaisdell. He emphasized the importance of creating culturally based health services for Native Hawaiians to prevent disease. In 2002, he launched a statewide initiative, the Men's Orkane Initiative. This was a discussion across the state amongst men about issues that they face in terms of seeking and obtaining health care. And this discussion led to the Kane Initiative in 2008, also named No Keolopono Onakane for the good health of men. And this was composed of this is a train the trainer community-based intervention where Kane volunteers or men volunteers in the communities will facilitate discussions groups amongst other men about their health status and health interventions that they could perform. This is the current project. It's been renamed to Kuola, or Upstanding and Principled Living. The project is led by a community advisory board. We have a Native Hawaiian community advisory board here at the Cancer Center, and they attend to all the research that affects the Native Hawaiian communities. We have representatives from across different disciplines, cultural representatives, as well as physicians. Picture here is Dr. Reginald Ho, a former national president of the American Cancer Society, Dr. Claire Hughes, who is considered a living legend in the Hawaiian community, who was part of the establishment of the Native Hawaiian healthcare system. And they lead our Native Hawaiian Community Advisory Board and provide advice on the research that we do, as well as to how we can disseminate our interventions across Native Hawaiian communities. So Kuala itself was formerly No Keapona Onakane. It's embedded in the cultural practice of the men's house. In Pacific Islander communities, food preparation was done by the men. It was very labor intensive. You had to catch the pig, build an emu to cook it. You had to high level fishing and aquaculture. You had to climb the coconut tree, husk the coconut. It was very labor intensive. So the Halimua Men's House was the institution where the transmission of this cultural knowledge was passed on from men to men, and it led to the process or sustainability of building stronger and healthy Hawaiian communities. And from our discussions across the state, this was the institution that the men wanted to reestablish as a vehicle to talk about health and to promote health outcomes. So this is what we use today. So it's really a small group education for men, Kuola. It's developed from the previous discussions. We train men in each community to lead the discussion. It's not led by a cancer center staff. It's led by men from the community. One of the key features is that we have physicians, Native Hawaiian physicians, who attend the sessions to answer and provide expertise in answering health questions that come up amongst the discussions with men. Our initial focus was on interventions like colorectal cancer screening and tobacco use. But having discussions across the state, we found out there was a lot of interest in establishing cultural practices or reviving cultural practices. A lot of the elder folks who were experts in these cultural practices were passing off. And so they wanted to revive those cultural practices. So we have the different types of modules. These are the four health promotion modules: lung health, oropharyngeal health, and colorectal health. But we also have newer modules. We have cordage or kala, prayer, pule, diet, ipono, fish ponds. Cordage may not seem like a health promotional topic, but in Pacific Islander cultures, there was no metal. So in order to build structures and seafaring vessels, cordage was a very important process. And, the idea of having to go out into the forest and identify cordage that would be strong enough to sustain structures was embedded into this and a part of the discussion about health, about how important it was to maintain health in order to perform these duties as part of traditional practices. So we were very successful. This is our example of our dissemination pre-COVID. We had about 400 men who were participating in the project. We had 14 community sites. The project was statewide. We had the colorectal discussion on traditional Hawaiian diet and health. And we also offered the opportunity for men over 50 to take a fit test. The reason this was important because prior to this, was noticed that only 40% of men over 50 had a screening for colorectal cancer. So we wanted to address that. So as a result, we were able to screen about 115 men as part of the project, and a good percentage of the men reported being up to date with their colorectal screening. And as well, men were highly positive about the opportunity to learn about colorectal screening health. So the project has morphed and expanded, and now we are working with families. We have what are called Halawai. Instead of the discussion groups, we actually include families into the health discussions. They identify cancer-related topics of interest for their specific communities. They help us identify experts to provide the information within their communities, and they also determine how these discussion groups and these meetings are held in their respective communities. So the idea behind COIL is to build capacity. We don't want it to be grounded at the cancer center, but we want to build capacity within the communities in a train-the-trainer and a sustainable manner. So we work to establish formal MOUs with community organizations. We identify elders who can provide some of the traditional practices and knowledge that is being lost. And we want to make sure that ownership and empowerment is provided for community members. Also, as part of this, we actually provide pilot funding for community-based research. So within each community, pilot funds are available to initiate research projects for issues that are important for that respective community. We provide scholarships for community members, to actually help them identify potential academic and scientific careers and provide scholarships to support their training in these efforts. And then we have our community partnerships, MOUs, where we provide actual funding to the community organization to be part of our project, as well as to support the activities that they would like to conduct to promote health within their communities. In addition to this, at the Cancer Center, we actually provide cultural competency training for all our staff. We've been doing this for about a year now. This is supported by the Department of Native Hawaiian Health at the John A. Burns School of Medicine. We have cultural experts that train our staff members about Hawaiian cultural practice and Pacific Islander cultural practices to provide a sense of place for our new faculty as they come on board to get an understanding about Pacific Islander and Hawaiian cultures. And this is a half-day workshop that we've been able to support and continue to support. And then finally, we have our mobile clinic. We were happy to get this a couple of years ago. This is our mobile clinics in conjunction with the Native Hawaiian healthcare system of Oahu, or the island of Oahu. It is a fully functioning clinical setting. We can actually go out to remote areas and deliver healthcare interventions with this clinical vehicle. Another feature of this, it has a Wi-Fi connection. So we have a network of laptops where we actually train community members on ways that they can identify credible health information over the internet to support their health promotion activities. So we're really happy about this. And then finally, this is a collaborative effort. It's not just the University of Hawaii Cancer Center. This is a collaboration of many, many, many organizations across the state. We've been doing this for more than 20 years, and we have a lot of support from a lot of different organizations. So we're happy to have this type of support, this type of involvement from the community, and we hope that we can extend this out and continue it for years to come. So with that, I'm going to stop and happy to answer any questions when that point in the presentation comes forward. So thank you.
Oh, Yakwe. Um, Thank you everyone for being here and sharing the time with Dr. Castle, Dr. Lim, and myself, and the ACI for putting this on. Uh, One of the things that I'll be sharing is that, as Dr. Lim mentioned in the beginning, the University of Hawaii Cancer Center and the work we do has faces two very different contexts and populations. So Dr. Casso shared with you the context of Hawaii, the state of Hawaii, and what's happening there. But the other part of the context is the whole Western Pacific, which I will be bringing into this conversation as to its context and its cancers and so forth, and how we try to work together in partnership with many groups to kind of decrease the cancer uh, uh, health disparities by risk reduction and cancer research in the Pacific as a team of many. So one of the things I find very important is I like many speakers. I'm not an expert, anything, but I bring a perspective. But you have to know what my biases are and what my lens is in discussing this with you because it does have an edge to it. So I have like many of us, different. I'm the son of a plantation labor immigrant, and my grandfather was brought to Hawaii in 1914, and my father, a bunch of years later, to work on the plantations of sugar plantations of Hawaii. So I have that lens. I'm a professor. I'm an academic, as Dr. Lim mentioned, both at and I'm a practicing physician. I teach resident physicians, and I do inpatient and outpatient care. I'm a dual citizen. I'm a citizen with a passport um, from the Marshall Islands, but I'm also a U.S. citizen. I lived in the Marshall Islands, one of the areas, for 9.5 years, and the years are there. Um, and I did a couple things when I was there with the U.S. Public Health Service, National Health Corps, but I was a medical director of public health there. But specifically, I was asked to develop programs to care for the people in the Marshalls who were affected by the nuclear weapons testing of the United States. So I have that lens. And I've worked 30 years across the Pacific in all the different countries. Every country that we're discussing, I've actually worked in cancer programs and other programs. And then from a grants and research standpoint, we developed a Pacific Cancer Registry, cervical cancer projects, I work on infrastructure research grants, several U54s, all NCI or NIGMS funded, CDC funded programs. So I work across these dimensions, but it's my way of saying this is the bias I carry in the story that I'll be telling you. And it's important for you to know so you can tell, wait a minute, where does this lens come from? So I have no personal relationships or affiliations, commercial interests, but the views expressed are not Cancer Center, not JABSOM, not Hawaii Pacific Health, where I do my clinical work, but it's what you saw. It's coming from the lens I present. So I will be talking about the Pacific Islander context, mostly in the Western Pacific. So, the indigenous people of the U.S. affiliated Pacific. Certainly, there's native Hawaiians, and Dr. Castle discussed that, but there's Palauans, there's Samoans, Marshallese, Krishnaits, Chukis, Chamorros, Carolinians, Pohnpeians, Yapese, and they are, not only Polynesian, these are Micronesian, and some are actually part Melanesians. And I won't go into that Pacific Island context, but they're not all the same. They don't all, they're not the same anthropologically, how they're spoken about in the way that their language developed and their all of their culture roots somehow are a little bit different. So this is a map, and you've seen several maps, but I just wanted to share that the target is where the Marshall Islands are. It's the Federated States of Micronesia. Yap is way out here, Northern Marianas, American Samoa, and this is Hawaii. And again, just the air flight from Hawaii all the way to Guam is 8 hours. To get to Yap is another 2.5. So it's a big distance. And, from the island of Hawaii to Houston, Texas, is the same distance as Hawaii to Guam. So just distance. And context is everything. Context is everything in all illness and working with it and understanding the origins of, I believe. And so in the Pacific, the U.S. affiliate Pacific, there are three U.S. territories, Guam, American Samoa, and the Commonwealth Northern Marianas. And there's three freely associated states, the Federal States of Micronesia, Republic of Marshall Islands, and Republic of Palau. And I'll be describing why this makes a difference. But this are the Pacific we'll be talking about. So many of you may or may not remember, but where did the U.S. do 80% of its nuclear testing, and where was a hydrogen bomb developed? It was in the Marshall Islands. There was 12 years straight of nuclear testing above ground in the Marshall Islands. And many of you may or may not know this. Of course, cancer is an issue, but other things. But this is the dimensions that we start with, is the Pacific was brought on for certain reasons in the war and so forth, but it was also part of our weapons testing grounds, and this is what it was used for. And this is, the Bikini Atoll, where the Bravo detonation, the biggest bomb, fusion bomb, was developed by the United States, and we still, it was 1,000 times the megatonnage and power of what was dropped in Hiroshima, one bomb. And so the other thing that is a marker for us in context is there's a lot of, as Kevin said, Dr. Castle said, in the Pacific, these islands are sometimes low-lying, but the whole paradigm of development and so forth, and how climate shifts, and maybe true, not true, whatever, but it's flooding the taro fields. So it's one where climate change and the reaction of what larger countries and things do affect, whether it's policies and testing or flooding fields. So you see this, and this is in Yap. This is the storm that has come through. This is the kind of ravage that it creates on these islands. So again, the context is important of what these islands are, how they came about, and how the world affects what's happening in this context. So what are freely associated states? So remember, the Pacific is, that we work with is territories, but there's also what's called freely associated states. And what these are, and it's the Federal States of Micronesia, it's the Republic of the Marshall Islands and Republic of Palau, but they're sovereign nations that are linked to the U.S. by a treaty called the Compacts of Free Association. Why are they linked by a treaty? It's because the United States, in essence, it can, in essence, what happens is that the North Pacific, which is where these countries are from, the United States has agreed with them that they will own the air, land, and ocean for strategic rights, military provisions, it's called. So uh, the United States says you're sovereign, but because we want to work with you to have control of the military dimensions of your lands, we will provide you the ability to give you federal grants, will help with economic assistance and development, and your citizens can work freely in and out of the United States anytime, flying out without a green card, though you're sovereign and you have your own passports. The Marshall Islands is one of those passports. That's why when I say I'm a dual citizen, really I'm a dual citizen with another sovereign nation. So that's what these are. These are compacts, but that's why they move freely. But they are very much present in all of the United States because they can move freely because of this agreement. Now, what does it mean? Context is important. So American Samoa, Northern Marianas, and Guam, as you can see from this chart, these are all territories. They're like the United States. And so they all carry United States passports. None of them can vote for the US president except citizens from Hawaii because it's a state. In the Republic of the Palau, Marshall Islands, and Micronesia, they carry their own nation's passports. They're sovereign nations. They also do not vote for the United States. All of the folks here can work and reside in the United States. All are invited to and have a heavy presence in the US military. So you can see the context of politics and how it works makes a difference in what happens. Secondly, a lot of folks think, well, they're all linked to the United States. It's all good because they all get lots of money and it's fine. So context matters. So this graph depicts total healthcare expenditures in these areas. So this is the United States. We're way over this now. 10,000. We're probably about almost $12,000 per person per capita per year in the public sector's expenditures in health. But you look at the territories, Guam's right around 2000. But if you look at the freely associated states, you have $228 per year. They're part of the US family, not quite, kind of. So this begins telling the story of what disparities are about, why context matters, and why health outcomes are the way they are, and what we are seeing. So in the Pacific, in the US territories and the compact nations, of course, like the United States, you have a very high rise of diabetes, the NCDs, cancer, atherosclerotic heart disease, renal failure is kind of really shooting off. But in the compact nations, that you have another dimension of health, which is still there. You have TB is still endemic in some of these areas. Hansen's disease is still endemic in some of these areas. Cholera is less so, but was there certainly in big time when I was there. And when I was in the Marshall Islands for 10 years, there was a syphilis epidemic. And we had to do mass syphilis screening and treatment. But anyway, the point is when you have a place that speaks to both infectious and NCDs, you have the slam from both ends, developed nations and developing nations. And that's what you're looking at in the Pacific. And so this is a very busy slide, but what it tries to portray, we've actually quantified the kinds of things in cancer that are present, whether they be mammography, pap smears, on island, and we broke it down not only by what they are, but the countries. And I won't go through all of this. And then we talked about, do they have a pathologist? Do they have on island histology and all of these different things in these countries? And then we also talked about, do they have an MRI on island, a general surgeon, and so forth. But the punchline is this slide is in the Federal States of Micronesia, one of the compact nations. There is no countrywide mammography available. It doesn't exist. This is and this is, 2025, and they don't even have a mammography machine. And so you're wondering, well, how do they get this? And Dr. Lim talked about, and then so in FSM, Palau, American Samoa, even the territories, there's no oncologist on site. There's no radiation therapy. FSM, RMI, and Palau, there's no island histopathology. And what does cancer care about? A lot of it is about at least having this minimum infrastructure. And so again, this context matters, and you can see what's happened in the context of why don't they have this? Good question. And so this was talked about by Kevin and Dr. Lim, both Dr. Castle and Dr. Lim. And we see here that this is Hawaii's population. And of course, Native Hawaiians, have not only the one of the highest, this is breast cancer incidence and mortality. The mortality is the gray, the brown, and the incidence is the red. And so you can see that the different populations is different. Obviously, but the Native Hawaiians not only have for breast cancer incidence and mortality, they have the highest incidence, but Japanese close. But notably, they also have the highest mortality. And so, across proportionally. So it's interesting this way. Why is that? And but if you look, and one of the things I want to share with you, we don't have this kind of very specific data about cancer, but what I want to share with you, this is Hawaii during COVID. and why I'm painting that context matters. This is Hawaii's populations. But what I want to show you in the COVID years, the Hawaiians actually are 21% or 22% of the population. It's the second column here. They're about 21%, but they owned 18% of the COVID infections. 18%. So they're actually proportionally we're doing okay. The Filipino population is about 16%, but you can see they were 20% of the infections. The other Pacific Islander migrants, not Native Hawaiians, but the populations from the Pacific that moved here, they're only 4% of the populations. But not only were they 4%, but they owned 24% of the infections and had twice the death rate of anybody. Context matters. Why is this? And we have to understand this. Of course, this was COVID, but the same principles play out. Something about the context of Native Hawaiians during this, there was an asset about being in Hawaii. For the Pacific Islanders, there was no asset. There was something lost. And the same applies if it's cancer, NCDs, and all the rest of it. So one of the things that cancer is related to risk factors of the Pacific. So one of the things on the left is all the countries. And, if you look at the tobacco related, obesity related illness, you can see that from a cancer dynamic, tobacco related to cancer, obesity related to cancer, we know that. If a screening test is available, all of that. So what we try to demonstrate in this is that in American Samoa, 82% of their cancers are tobacco related, obesity related, but all of this is preventable. And that's what's remarkable. A lot of these things are preventable. In the Marshall Islands, 60% of their cancers are tobacco related, 38 as a, and so, and then also the percent dead within 5 years of diagnosis, you can see in all these countries, the percent dead, which means they're picked up at late stages and there's nothing to treat them with. And so again, this slide tries to capture many of the cancers preventable. We know about that. Very high mortality because we don't have the interventions and the knowledge for prevention, screening, and that's the paradigm that we're working in. And then I work a lot with cervical cancer, and just to show you the differences, and this is just in um, the best this is cervical cancer rates, and in the WHO northern this is the rates worldwide. So in general, using U.S. standard rates, the cervical cancer rate in Hawaii and the United States is about 7 per 100,000. Using the world standard, it's the WHO standard for North America is about 6.1. In the Marshall Islands, it has the highest rate in the world. Not in the Pacific, in the world. It actually beats out Southern Africa. Pohnpei is not too far behind that. And this is the US Pacific. This is the US Pacific. What's wrong with this picture? And so again, context matters, and why is this? And so there's differences not only between the Pacific Islands but oftentimes they're compared to the Asian population and so forth. And I won't go through this slide, but it just says you have to break this down not only by the context of where they're from, but and ethnicity, but history and so forth. And so why this slide is the attempt to show that when the Pacific Islanders said, we have to not only understand this, but within. So they formed this Cancer Council of Pacific Islands, and it's a partnership, but they formed a group that said, we're going to understand this from within. And these are all the people from the U.S. affiliated Pacific. We began this group, and notably, this guy is Dr. Harold Freeman, but was head of the NCI research disparity branch. But anyway, many of you probably know of him, but he actually provided the funding to develop this group. And this is back in 2003. And from there, developed this entire group to kind of galvanize understanding cancers in the U.S. affiliated Pacific, planning for it, developing this partnership with the medical school, with the University of Hawaii Cancer Center. We developed cancer registries, we developed different cancer, cervical cancer programs. But the big uh, punchline for this is that it was something that was worked on as a region from within. And so that group, that planning group, came from that small group. And this is 2019, a picture that's actually, in one of the buildings here. This is the planning group now. These are the indigenous that said, we're going to do this. And they put together and we planned together about the cancer, how to deal with it in the specific jurisdictions coming together. But it was that inner work that has formed the registry. The cancer registry is just for the Pacific. It's collected a lot of the data we showed you, the planning, the helped develop some of the research paradigms and so forth. And so the waves of healing, it's what's happened, and Dr. Castle described it. It's rediscovering and applying the indigenous knowledge, and he talked a little bit about that. It's linking the Pacific and Hawaiian people's history and ancestry. It's using the intergenerational consciousness, and it's also taking advantage of the cultural trauma and healing and how we don't let that happen again. So the big cultural trauma and healing is not only colonization, but it's the nuclear testing and all those kinds of paradigms. It's about, the flooding from the actions of other countries and the storms, and it's protecting health through culture and tradition. It's the children passing the knowledge and allowing them to do that. It's becoming part of the caring environment. It's creating the space in the work we do for uh, incorporating tradition, change, and culture. And Leiku Kova'a, that's actually my daughter's name, but it's one of it's in the traditional way of the Pacific, and the healing waves. It's understanding that the ocean, land, and wind and stars own their own genetics and environmental dialogue. We are part of that dialogue. We can heal in that dialogue, but somehow Pacific Islanders, other people have separated themselves from that dialogue, and you get a lot of illness states. And I know this is, people are going, what are you talking about? Well, that's what we're trying to understand, what we're talking about. I don't even know lots of this. Environment offers a constant to frame, and the word, aina in Hawaiian, it's, a lot of people say, well, the aina gives the energy. It's the land gives the energy, the ocean gives the energy, but aina, the part I, means anything that feeds you. It's not just food, it's the wind, it's the stars, the environment. And that the researchers, us, are the people that are integral to the dialogue, but we are the sailors in the dialogue. We are the navigators. And the concept that we are trying to work on is that the people who have the lived experience, the people that are in the context that you've seen, become the researchers, not are the conduit to the research, but they are the researchers. They are the discoverers of new knowledge. They own the data. They build the data. They are the genomics, and they sustain the dialogue. And I think that is the trying to move in that direction, as opposed to they are the conduit to the research that we are all doing. And so the indigenous programs, we do these many different things in the Pacific as a way to move this dialogue for build registries. We do community engagement, Pacific telehealth programs, comprehensive cancer control, different grants and so forth. And we do these policy changes, training, a lot of these different things are occurring. Research, translational and disparities research, capacity building. But the one that I'm highlighting in yellow is probably for me, the most important thing is the people capacity. It's researchers increasing the numbers and capacity of researchers who have the lived experience into cancer researchers, into our cancer center, other cancer centers, because they're the only ones I believe who can develop, lead, and conduct highly quality, relevant research and sustain it in their populations. Other people kind of sail away. And so this is a model that of all the things that have been developed, but the journey in the Pacific that's been part of the what certainly I've been part of and many of us on here have been part of, but it's that taking and being not an observer of the canoe, but being on the canoe and the indigenous lived experience people should be the ones that are driving, guiding, and sailing this canoe over this course. So thank you very much. And that's my part of the sharing over.
Thank you so much for the presentations, Dr. Castle and Dr. Palafox. I mean, I always find it really helpful myself and interesting to kind of understand the historical context for the cancer inequities that we see today. Um, we have a Q&A box, as Haley had mentioned, that anybody can please feel free to answer or ask any questions. If not, I will ask one question. So, it's so interesting. The cancer treatment landscape today really have changed significantly over the years to a lot of the novel therapies that we see, right? And infusions that re really require patients being very close to the infusion center, to a big academic center to look for any side effects. And I think one of the worries that I have is that the disparities gap will continue to widen because not only are these therapies not going to be as accessible to these patients, right, from native islands, Pacific Islands, like we all mentioned, but I worry that the idea of novel therapies like genetically engineering, like CAR T cells, right, just won't be as easily accepted in that population. And so I guess my question to both of you is that as we move forward, I mean, do you have any recommendations on how we can kind of gently mitigate this gap?
Uh, Kev, did you want to jump in
Oh,
or I
I'll
can?
let you
Yeah.
jump in. I do have some ideas, and this is exactly the challenge, the geographic disparities that we experience, people from neighbor islands, people across the U.S. Associated Pacific. I think one of the first steps is we try to, have, satellite facilities. We were fortunate to be able to get clinical trials onto in Guam a few years back. But those types of initiatives, we need to find champions for cancer care within the jurisdictions that can hopefully, translate some of these therapeutics, particularly on the neighbor islands. There's a big push now for us to extend treatments to the Hawaii neighbor islands. It's very challenging to do that. It's very challenging to get it done, but I think that's where we need to go. We need to go with getting champions in these jurisdictions, in these remote places, and getting the therapies out there either through telemedicine or other vehicles. But that's my thought. I think we need to push for that, that's I think is very, very important right now.
And to add to Dr. Kevin's point, Dr. Lim, is that I think one of the things is, and I'm a strong believer in this, is that I think the community has the answers, but they're not allowed to be at the table and in many dimensions. So it's bringing them to the table in a meaningful way to help answer the questions, because setting the priority, how to get the resources to do this, they have a lot of wisdom there, but it's sometimes we try to, I think from the academic and other standpoint, we want to say, no, we kind of know how to bring the car RT cells and so forth. But I think working with them, I'm just amazed how they can identify resources, work with the people, but also might say, you know, Dr. Lim and Dr. Castle, uh, maybe car RT cells is not the now answer. It's part of the answer, but let's get some good prevention. And then when we get that, then, we're going to go full guns and get the access to these, because then you'll have a less of a load to deal with in your fine technologies. But I think bringing them to the table as the actual researchers and people, not bystanders of the paradigm. So that would be my thought, which is of course a lot of work, but it's something that I think is something to work on.
And I think vaccination rates too, right, are lower within the Native Hawaiian and the Pacific Islander population. So to your point, Dr. Palafox, about the cervical cancer rates, I mean, I'm sure the HPV vaccine rates are going to be much lower within that population. Access to the HPV vaccine may not be as high too. So, I think there's other ways that we can work to help lower these cancer rates, with all of your insightful suggestions. So that was great. Okay, so we don't have any questions. Thank you everybody for being here today. And yeah, hope you have a good rest of your Wednesday. Thank you, Dr. Pavlock. Thank you.
Thank you.
Thank
Thank
you.
you.
Basil.
Thank you.